Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all attendees, respected speakers, and chairmen. Welcome to the 34th weekend course of cardiology, especially in plenary session 2. This session is open to public and will consist of two topics. The first one is changing paradigm of lipid lowering in primary and secondary prevention of CAD. And the second topic is pulmonary hypertension in congenital heart disease. This session will be chaired by Dr. Iwan Dakota. Dr. Iwan Dakota is a senior cardiologist in vascular division and also the president director of National Cardiovascular Center Harapan Kita. To Dr. Iwan, please, the session is yours.
Thank you very much for the giving opportunity. Dear colleagues, ladies and gentlemen, this afternoon we have very interesting topics, which we have two very prominent speakers, Professor Kaushik Ray from UK and Dr. Indriwanto. So let me introduce Professor Kaushik Kumar Ray. He is actually the president of European Atherosclerosis Society. He actually is professor of public health and consultant cardiologist. He is the director of Imperial Center for Cardiovascular Disease Prevention and deputy director of Imperial Clinical Trials Unit and head of commercial trials, Imperial College of London. Today, Professor Ray will give talks about the changing paradigm in prevention of primary and secondary prevention of CAD. This would be very important. May I invite Professor Kaushik Ray?
Great, thank you so much. Really nice to be with you today, albeit virtually, and I hope you're all doing well. And I think these kind of weekend programs have really helped us at a difficult time where we couldn't travel and do face-to-face meetings to actually have these type of discussions. So I'm just going to find my talk and then we'll be able to begin. Here we go. Okay, so I think we need to really start by thinking about what it is that we're trying to do and what we want to prevent. We should not think about cholesterol lowering. There is this kind of tendency to think about medications for cholesterol lowering as only for people with high cholesterol. And that is not the case. The reason that we are interested in cholesterol lowering is to reduce the risk of atherosclerosis and the clinical consequences of that when they present acutely with myocardial infarction, ischemic strokes, or the need for revascularization. These are a list of my disclosures, and I want to start with this. And I think for all of us, it's really important to think about healthcare systems and change. Our healthcare systems are largely focused on treating disease, not on preserving health. Why do I mean that? Well, most of us work in hospitals. It's only the very sick that will usually come to us over here. And if you think about everything that we've missed in the past, we're born with a genetic vulnerability to adapt to our environment, or we're born with genes that are maladaptive. And then over the course of our lives, we basically are exposed to multiple different risk factors to varying degrees, and it's not a constant exposure. It'll go up or down for some of these things. You can move to areas of low pollution, for example. You might stop smoking, you might lose weight, all of these things, but they happen over a period of time. So what's important is genetic vulnerability and the interaction of that between multiple causal risk factors and the duration of that cumulative burden, if you will. So we kind of largely think about things here in terms of palliation rather than here in preserving health. And this is where, if we want to save future disease, ASCVD, and prevent that, we have to think about primary prevention earlier and potentially, for some people, more aggressively. This is the disease, the underlying process that we're trying to fight. You're born with relatively normal, clean blood vessel walls. Then over time, with deposition of cholesterol in the blood vessel wall, the lesions progress from foam cells, fatty streaks, all the way to more unstable plaques that are rich in cholesterol, thin, fibroelastic cap, and more vulnerable. But all through this process, our patients are asymptomatic. And that's a real problem because they don't tell us that this is happening. It's not like a patient with worsening asthma or heart failure until they present. And that's a real problem. And if you look at this, it doesn't make any sense that the person with this level of underlying disease should be treated in the same way as somebody here, for example, who is on this trajectory to become here over the next 40 or 50 years. So we have to think about all of these things in a slightly different way. Now, what about LDL lowering? So 1 millimoles, for those of you that use milligrams per deciliter, is 38 milligrams per deciliter. So 2 millimoles is 78. When we look at clinical trials, it's not the percentage reduction that determines benefit, it's the absolute lowering. So if you take somebody from 100, for example, to 50, or you take somebody from 150 milligrams per deciliter to 100, for example, that 50 milligrams per deciliter lowering will give you the same relative risk reduction. So, but the amount of benefit, the number needed to treat, will vary depending upon your underlying risk and other comorbidities. When we do trials, the follow-ups that we have are no more than about 5 years. So when we look at RCT data with drug therapies, a 38 milligrams per deciliter lowering gives us 22% relative risk reduction. But there's no perfect normal cholesterol, because the more we lower LDL, the more benefit we get. The other important thing is the benefit of time and maintaining this difference over a longer period of time. So if we look now at observational data, it's a straight line again, there's no plateau. But the difference now is we have 12 years of follow-up. And so the slope of benefit is steeper. So 38 milligrams per deciliter lowering will now be giving us about 33% relative risk reduction. And if you look at genetic studies, so-called Mendelian randomization, then that same difference maintained over 50 years will give us over 50% lowering. So the two things that matter are how much we lower LDL and how long we maintain it for. Now, if we move to guidelines and we look at what guidelines say, guidelines, first of all, ask you to look at some form of risk assessment. And that basically means you have to have some estimate of their 10-year risk of cardiovascular events. Now, for some people, it's relatively easy because they've got clinical manifestation of cardiovascular disease. So there are secondary prevention patients. But what's often harder are these primary prevention patients who've never had disease before, but clearly have abnormal risk factors or multiple combinations of risk factors. So their 10-year risk is actually going to be similar to this group here. And we've got to get used to treating primary and secondary prevention patients where the 10-year risk is similar in the same way. You don't want to undertreat very high-risk people because you will leave them at high residual risk. But similarly, for low-risk patients, you do not want to overtreat. So if we start treatment early enough and lifestyle and other things change, then small changes but maintained for a long period of time should be enough. Now, there's one important caveat now, because guidelines have changed to recommend more aggressive and lower LDL cholesterol goals, which is our principal target. After that, we follow non-HDL and ApoB as lipid targets. When you aim for an LDL of below 55 in your highest risk patients, how are you going to get there? And to do that, we need to look at the slide on the right-hand side. Statins are clearly first-line therapy, and statins should be first-line therapy. They are cheap, they're available around the world, and they are effective. But on average, the maximum lowering with a high-potency statin you will achieve is about 50% lowering. So if my starting LDL is higher than 110, it is unlikely that my patient will get to below 55, which is the target in my very high-risk patient. So in my mind, mentally, I should already be thinking about the need for combination therapy. And that's really important because often patients show response to the first treatment, but we don't up-titrate medication. So to demonstrate this or to study this in more detail, this was a registry in Europe, which I led, called Da Vinci. And what this showed in Europe, when you manage very high, moderate, and low risk patients, basically, that the way we are practicing is statin-based monotherapy. So about 84% of our patients get a statin at some dose, mostly moderate, and about a third at high. Combination therapy is not used very much, or wasn't, in 2017, 2018. And what that resulted is that in our older guidelines, which are easier to achieve in 3 of the categories of risk, 1 and 2 would get to goal. But when we shifted the guidelines to more aggressive goals, and the shifts were only small, about 20 milligrams per deciliter for 3 categories changed to lower LDL goals. This approach of monotherapy is only going to work in 1 in 3. So either you believe the guidelines aren't what you should be following and the data that they're based on is flawed, or you have to accept you're going to have to use combination therapy. It's as simple as that. And then the question becomes, all right, but what? So I think to illustrate that, I've used this example from post-myocardial infarction patient, really just showing you the population distribution of LDL. So this is what it looks like here. This is at the time of admission. So you can see this is the goal, 1.4. Some people had an MI with actually low LDLs below 55. Maybe they've got so many other comorbidities, that's why. But they all got given a statin. So the population distribution of the curve moved to the left for LDL cholesterol. But everybody to the right is not going to get there without something else being done. Now, the first approach is to up-titrate the statin, but we've already got there anyway. With most people, got the biggest return. So when you double the dose of a statin, go from 40 to 80 of atorva, you're only getting another 6% lowering. So this curve looks like this. Where we start to move those outliers to the left of that black line is when we start to add in a second or a third drug. This is the addition of ezetimibe. So this lowers LDL. Everybody to the right moves by 25%. But then we've got PCSK9 directed therapies, which when added on to drugs like statins, can move people over to the left and reduce LDL by 50%. Because of that clinical inertia, this was something that we wrote, which was essentially that for established cardiovascular disease patients, you should just start with combination therapy. And you should start with combination therapy where essentially you can then reassess those patients. So if somebody came in, for example, on a statin, but a low dose, you'd maximize the statin, but you've got to add in ezetimibe. And that will allow you probably to pick up about 50% of your patients and get them to goal. So then all you have to do is worry about those people who are not at goal, above 55 mg per deciliter. And for those, we have injectable therapies, we have other oral agents as well that come in. And if you're a high-risk patient where you've already come in with prior recurrent events, this is no prior disease. But if you're somebody who came in on a statin and you've had a myocardial infarction, you should probably go straight onto triple therapy, realistically, with those people, because your risk is very, very high. You can't just look at LDL goals in isolation without looking at risk. So in that same Da Vinci registry, with demographic characteristics, we can estimate 10-year risk in a secondary prevention population. These were the type of cardiovascular diseases people had: CAD, PAD, cerebrovascular disease. 61% of patients that are LDLs above the old goals of 70, the new goals of 55. The average LDL is 93, and their 10-year risk is 32%. Now you can say, well, okay, let's get to 70 and see what happens. So if everybody here got to at least 69 mg per deciliter, 10-year risk would come down in this group to 28%. We'll have reduced absolute risk by 4%. But the relevant to do that, we only need to change LDL on average by about 24 milligrams per deciliter in that cohort. But to get people below 55, for example, there is benefit, but we're going to need a bigger absolute reduction. 39 mg per deciliter. So the ability of different add-on therapies to give you this bit extra is going to vary. So now when we get these people to this goal here, we've now changed absolute risk by 6%, and their 10-year risk has now come down from 32 to 25. And then finally, because there's no limit, if you move everybody down to below 40, to do that, you're going to have to gain another 52 milligrams per deciliter lowering of LDL cholesterol to get people to this group here. And that basically means now their 10-year risk is 23%. It's almost 10% lower than they started with. But you've also got to be careful and not ignore the people at goal, because here 39% of people had an LDL of 56 milligrams per deciliter on average, but they had so many comorbidities, low HDL, chronic kidney disease, diabetes. So their 10-year risk, it was 35%. So an argument could be made for bringing these patients apparently at goal 56 down even further to reduce this excess risk of cardiovascular disease. So combination therapy is needed, but combination therapy traditionally has relied on small molecules. And there's a problem with small molecules is that you have to rely on patient adherence. So if we look at LDL reduction that's achieved, it depends upon two things. Compared to a patient who doesn't take medication and the doctor hasn't prescribed anything, and that's our reference group, your LDL reduction depends upon what you prescribe and what the patient does. And adherence is very important. So a non-adherent patient, irrespective of what you give them, the LDL reductions are going to be here. Drugs can only work if you take them. So now if you've got people who are better adherent, going from low, moderate, and high intensity statins, you gain bigger reductions in LDL. The best scenario is when you prescribe a high intensity statin and the patient is fully adherent. So that's an important concept for LDL lowering. And it actually follows that when you look at risk, the same is true. The lowest outcomes or the best outcomes are basically when we prescribe the right intensity of treatment and the patients follow that advice and they take them. So we have to basically, with small molecules, make sure patients are adherent. Now, we have other new ways. Technology has allowed us to evolve and offer new ways of lowering LDL. They are RNA-based therapies, and there are two approaches, antisense and small interference RNA. What is the difference? Well, they both, in terms of cholesterol regulation, will work on proteins made by the liver. And the big difference between the two is that small interference RNA and the prototype of that, if you will, or the first approved drug, is inclisiran. All of these sRNAs are double-stranded RNA. And in the cytoplasm of all mammalian cells and in your hepatocyte, you have something called the RISC complex. This doesn't work in the same way as other medications. It's not like cytochrome P450 metabolizing small molecules, drugs. This is designed to bind naturally occurring sequences of double-stranded RNA, which are used by the body to switch off different messages, break down different message RNA. And that's how you switch off different protein production. So we can piggyback onto this. We can use this endogenous system by telling it where to go, what the target should be. So if we create a piece of RNA that is identical to PCSK9 messenger RNA, won't bind to anything else, it's retained in this complex, and it seeks out messenger RNA for PCSK9 by complementary binding. And then there's an enzyme here that cuts this, breaks it down catalytically. So it's a highly efficient process. You don't have to target downstream the protein. You just go upstream to the code that's making it. It's not changing DNA, not editing DNA, it's inhibiting translation. Now, we can also do this, but in the nucleus with an antisense. It's a single strand of RNA. This now has to get into the nucleus. And the only difference between these two approaches is this one probably once a month dosing and this one twice a year dosing. It uses a different enzyme called RNase H, but again, that complementary binding, and this is basically being tested for LPA lowering. The second thing is to get this effectively and efficiently into the liver, so that the larger the dose that we use, is the more potential for side effects. So one thing that's really helped us is the discovery by a group in Leiden that the acyl-glycoprotein receptor is present on the liver. And what this does is it recognizes aging senescent cells. And what this does is then remove them from the circulation. So if this recognizes something on aging cells, what is that? It's a sugar residue that these cells express called GalNAc. Now, if we add that onto any drug, all of the drug will be available within 4 hours in the liver. So you can't measure anything in blood. So that's a highly effective way. And it means we can reduce the doses that we need, but still get the same effect. So when we first tested this drug inclisiran, we were selecting a dose. Look at the 300 milligram dose, the blue dose in the middle. A single injection can give you, within 30 days, 50% lowering of LDL cholesterol. But because of that unique mechanism of action, where you're shutting down messenger RNA, that long duration of effect on a highly targeted process, we now should be thinking about these drugs in a way that we haven't thought about small molecules before, which is the area under the curve. With a single injection, you're getting 41% lowering of LDL cholesterol. So it's not what the LDL reduction is here or here, it's the average that you want to basically look at. The reason with the dosing schedule, we give a second dose on day 90 is shown here. This is a single injection of inclisiran on day 1 or day 0, and this is a second injection on day 90. If you didn't give the second injection on day 90, your patient in this 6-month time window would gradually, from 50% reduction, the next time window, the reduction is only 41%. If you give a second boost here at day 90, the next 6 months, you've got coverage with a 51% lowering of LDL cholesterol. So we tested whether long-term we could go to twice-a-year dosing. And to do that, we use this schedule, day 1, day 90, 6 monthly thereafter, all the way through to 18 months. We wanted to look at the peak effect at month 17, but most importantly, the area under the curve between day 90 and day 540. So that's a 15-month window when you've moved to 6 monthly dosing. And what we can first start off is provide assurance because of that highly specific effect about safety. Adverse events overall, I won't bore you with all of the details, essentially identical. So we've got to be able to separate the long effect on LDL from safety, because there is no issue with safety. You can basically see adverse events are numerically identical, whether you look at system organ class or not. There's already a trend over 18 months towards lower events, and that's as much as you would expect. This is not a cardiovascular outcomes trial. They are ongoing. The only difference you will see, as with all injectables, is a small excess of injection site adverse event, a bit of redness, a bit of erythema in 1% or so, that somebody says, oh, I noticed this. But actually in clinical practice, now that we're using it, we don't see any complaints like that. You don't have to worry about adverse events and in terms of diabetes risk, in terms of liver function abnormalities, CK abnormalities, or anything else. There's nothing to monitor. And we know for FH, for example, these are 1 in 311 individuals are born with a faulty LDL receptor gene, largely. And even when you find them, with statins alone, you don't get enough LDL lowering. We basically compared 26 injections a year with a monoclonal against an siRNA twice a year inclisiran, and statistically the LDL reduction is identical. So if you ask the question, should PCSK9 lowering be used across FH patients, irrespective of genotype? And the answer is yes. It doesn't matter what the genotype is, the added value of any PCSK9 lowering therapy is huge. So that basically means find the patients, get them onto a statin, make more LDL receptors, keep them alive longer by lowering PCSK9 with any therapy that's available. So if you take all of these data, you can pull these together, and if you like, the peak effect on LDL lowering is 55% with inclisiran. But most importantly, the area under the curve, the blue, annualized reductions of 52% with twice a year dose. That's what you can say to your patients. I've got a treatment that, if we can get you onto this with 2 injections a year, will give you annualized coverage of 52% lowering of LDL cholesterol. That's what we can say. We can see reductions in non-HDL of 46%, ApoB of 42%, LPA of 20%. In clinical practice, these are some of the people that I've treated. This guy on the left-hand side started cholesterol-lowering treatment over 40 years ago. He was just told he had hypercholesterolemia. He's actually got FH. And he started cholesterol lowering a while ago, but his LDL on treatment, despite that, was 130. This despite statins and ezetimibe. He's got already CT evidence of moderate angiographic disease, not bad enough to need a bypass, but 20 years of still levels of about 130 to 140 have got him to this stage because he started treatment at age 40. We missed the previous 40 years. Single dose of inclisiran at 30 days after this injection, on top of background therapies, LDL is now 60. After the second dose, it's come down to 55. So his risk has changed quite considerably. His risk has changed and is now lower by about 40%. This is a 54-year-old MI patient who was taking alirocumab because he had premature disease and he was had achieved quite good LDLs, but he wanted to move to something that was more convenient instead of having to dose every 2 weeks. So we switched into inclisiran, and now his LDL is virtually identical, but it just through a much more convenient way. This is a man with carotid disease, can't tolerate first-line treatment, statins, has got CK elevations with statins, MAB couldn't tolerate, ezetimibe gave him diarrhea, polymyalgia rheumatica in the background. On inclisiran monotherapy, LDL went from 160 to 78 within 30 days. A couple of other patients. Look at this person, 45, family history of premature CAD, LDL 98, single injection, 30 to 45 days later, LDL now 45. And there are a few people that I can just show you here with really good reductions, both in LDL and LPA. 60-year-old lady, cardiovascular disease risk is high. On treatment, LDL 106, LPA 147. We think about high being above 70. Now the LPA has come down from 47 to 92. We don't have any other treatments for lowering LPA at the moment other than MABs and inclisiran. Now the LDL, look at this, 106 down to 35 milligrams per deciliter. And then finally on the right-hand side, this lady with an LPA of 90, an LDL of 102, 2 doses. Now the LDL is 15 mg per deciliter and the LDL is 43. So we've got good treatments and good options. We've got to put it into clinical practice. And this is what we're doing today by improving education, understanding. It's a bottom-up approach, though. That means that there are many, many hospitals. This is only one meeting. There are so many people still to work on and educate. However, if policymakers, if governments, if healthcare systems start to think about some of these things and think about the future, a top-down approach can help support this through investment in digital solutions, thinking about population health and starting earlier. And if we can do all of that, we can meet in the middle and actually within the next 50 years, change the course of our population. I want to share a couple of interesting things with you about adherence and variability in LDL and outcomes and how we can, with these new therapies, overcome that. These are placebo-treated patients, placebo injection, but they are on statins in the background. If I measure cholesterol at 2 time points, 180 days apart, some patients will go up by 50%, others down, which basically means that they are either taking them more or less at different time points. So when you add inclisiran in, everybody's getting additional benefit, even though this is actually happening in the background. And because inclisiran is designed to be brought in by healthcare professionals, you have an opportunity to change this in the background by reminding them to take those medications, because it's that combination that is now giving us 80–90% lowering of LDL cholesterol. Why is this variability important? Well, if our patients vary in their LDL cholesterol levels up and down over time, then on statins alone, then their cardiovascular risk is much, much higher compared to people who rigorously and religiously take their cholesterol. I want to give you a glimpse at the future. You know about the UK's approach. We're thinking about a population health model identifying 300,000 ASCVD patients. But what's the benefit? 4 minutes?
3 minutes, 3 more minutes.
Okay, this is my last slide. So basically now what you have is, if you think about the distribution of risk in our patient population, we've got some people with ASCVD. Not everybody has the same risk. Some will have less than 20%, 20 to 40, 40 to 60, 60 to 80, 80 to 100% risk. If we look at that 500,000 at the percentage and the absolute number, we've got 273,000 people with 10-year risk less than 20%, 179, 20 to 40%, 37, 40 to 60%. So we have smaller numbers, still large numbers in these very high risk groups, and their LDL is all above 100. Now, if we gave all of these people inclisiran, what would happen is, instead of 2,500 patients being in this highest risk group, we would basically have 222 patients in this highest risk group. Instead of now 7,600 patients in the 60 to 80% risk group, we'd only have 1,400 patients. Instead of 37,000 patients in the 40 to 60% group, we'd only have 12,000. And if we move from 179,000 patients in this group to this group, we've just reduced 80,000 patients. The numbers are getting bigger in the lower risk group. And in the lowest risk of group of all, we've moved those outliers to this group. We've gained 100,000, which is what we wanted to do. And if we can do this now over 50 years, by overcoming adherence through these infrequent treatments, we will get a better area under the curve. And if we map that over 50 years with these new therapies, we're going to get a bigger relative risk reduction. So in conclusion, there's a considerable burden of cardiovascular disease. Improving control of LDL can help stratify, can help reduce risk significantly once you've risk stratified patients. And it's very simple. Make more LDL receptors with statins or oral agents in the background, add in a PCSK9 lowering therapy to make those receptors live longer. And these new injectable therapies, because of their convenience, have the ability to transform population health. And what I'm seeing in the real world and what we are seeing worldwide supports the trial data as well. So I want to thank you for listening.
Oh, well, thank you very much for very important and very interesting talks, Professor Ray. We will move to the second speaker. So we have Dr. Indriwanto. So he will talk about the pulmonary hypertension in congenital heart disease. Dr. Indriwanto actually is the staff of cardiology and vascular medicine, especially in the pediatric department. He actually graduated from University of Pajajaran and then completed his cardiologist training in National Cardiac Center Harapan Kita, and then he got the PhD in University of Indonesia. Dr. Indriwanto will give talks regarding to the pulmonary hypertension in congenital heart disease. Maybe invite Dr. Indriwanto.
Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. First of all, I would like to thanks to the organizing committee to invite me to share topic about the pulmonary hypertension in congenital heart disease. So, first introduction, we know pulmonary hypertension almost associated with the pulmonary vascular disease. So the pulmonary hypertension have the characterized by pulmonary vascular remodeling, like elevated pulmonary arterial pressure, right ventricle dysfunction, and underfilling compression of the left ventricle. So, and the last of the disease is the heart failure. So now the pulmonary hypertension mortality has been decreasing in the children and adults. Why? Because the increasing awareness of this condition and its multiple etiologies. And now more accurate diagnosis we have better risk stratification and early initiation of combination pharmacology therapy. So, but currently, no cure. The experimental therapy is established to stop or even reverse disease progression and relieving the significant morbidity and mortality and improving the patient for the quality of life. That is more important to treat the patient with the pulmonary hypertension. Yeah, how about the pulmonary arterial hypertension associated with congenital heart disease? So in Taiwan National Health Insurance Administration in 1999 and 2011, the pulmonary arterial hypertension associated with congenital heart disease account for the 11% of the patient with pulmonary hypertension. So they found 5 to 10% of adults with congenital heart disease and almost left to right shunt due to congenital cardiac. How to lead increase the pulmonary vascular resistance. And then the Eisenmenger syndrome, the pulmonary artery hypertension with reserve central shunt and represent the most severe form. This is some paper two from the Taiwan. They found they differentiate about the all adult congenital heart disease with pulmonary hypertension and no pulmonary hypertension. So we see in the Kaplan-Meier survival here, there is significant lower survival in adult congenital heart disease with pulmonary hypertension. This is the red line. So Swartz et al. That paper say, but at the progressive increasing the pulmonary vascular resistance leading to right ventricle failure and premature death. And they account the prevalence of pulmonary arterial hypertension with the among various cardiac defect. So they divided the closed ESD, the prevalence is about the 12%, and open ESD without Eisenmenger is 33%. And of course, the open ESD with Eisenmenger is 100%. So equal with the VSD and open VSD with Eisenmenger, almost prevalence is 100%. This is survival of patient with the another cause. This is the one is pulmonary hypertension, is congenital heart disease, is left heart syndrome, is idiopathic. So we see the cumulative survival is better in pulmonary hypertension with congenital than idiopathic pulmonary hypertension. See here, this pulmonary congenital with congenital heart disease. This is in idiopathic pulmonary hypertension. So the precise of the pH impact, not only optimal treatment, but we must know the prognosis. Here, Chu et al. To the divided the pulmonary hypertension with the 4 or 5 clinical presentation like Eisenmenger, pulmonary hypertension with small defect, pulmonary hypertension left to right shunt, and pulmonary hypertension after correction defect, and then the complex congenital heart disease. So this is not significant from the statistic between all clinical classification, but we see in this survival Kaplan-Meier, they see the blue line is more worsening than the defect correction. Okay, we back to the definition pulmonary hypertension. Recently, the pulmonary hypertension, the definition is the increasing of the mean pulmonary artery pressure with the more equal 25 millimeter mercury at rest, and they assess by right heart catheterization. After that, they redefine again their resting mean pulmonary artery pressure more than 25 millimeter mercury, or mean pulmonary artery pressure with exercise more than 30 millimeter mercury. At the last World Symposium on Pulmonary Hypertension 2018, they redefined again, and both mean pulmonary artery pressure more than equal 20 millimeter mercury and pulmonary vascular resistance more than 3 Wood unit. So there is more lower than before. So here the update of parameter based on 6 World Symposium on Pulmonary Hypertension at 2018. They divided the definition three divided. So one, the pulmonary hypertension with the definition at or characteristic, the mean pulmonary artery pressure more than 20 millimeter. How about the clinical setting? Is all use the if the pulmonary artery pressure more than 20 millimeter, so we call a pulmonary hypertension. But in precapillary pulmonary hypertension, if pulmonary arterial wedge less than 15 millimeter mercury and pulmonary vascular resistance more than 3 Wood unit, they are called the precapillary pulmonary hypertension. What the clinical setting at the precapillary pulmonary hypertension? There is the shunt lesion prior to and after repair, including Eisenmenger syndrome and the complex congenital heart disease, including univentricular heart or segmental pulmonary artery hypertension. So the second, the isolated postcapillary pulmonary hypertension, their characteristic is the pulmonary artery wedge pressure more than 15 millimeter mercury and pulmonary vascular resistance less than 3 Wood unit. So where the clinical setting for the isolated postcapillary? There for the systemic ventricular dysfunction, systemic AV valve dysfunction, pulmonary valve obstruction, and coronary arteriatum. So the last is combined pre and postcapillary pulmonary hypertension. There wedge pressure more than 15 millimeter mercury, and then pulmonary vascular resistance more than 3 Wood unit. So this is the parameter based on the last symposium. So the important thing, mean pulmonary artery pressure of 20 millimeter mercury should be considered as the upper limit of the normal value. So this is the clinical classification, the congenital heart disease go into the pulmonary artery hypertension group 1. The pulmonary artery hypertension have the functional classification. They are divided to 4 classes. One is no limitation for physical activity, and the second is slight limitation of physical activity, and the third, class 3, is the marked limitation of physical activity that the patient is comfortable at rest, less than ordinary activity caused by undue dyspnea, fatigue, chest pain, or near syncope. And class 4 is inability of carry out of any physical activity without symptom. And this patient manifests sign of the right heart failure, dyspnea, fatigue may be present at rest, and discomfort is increased by any physical activity. So if before it is the functional classification, now is clinical classification of pulmonary artery hypertension associated with congenital heart disease. The classification have 4 clinical classification. One is Eisenmenger. The second is pulmonary hypertension associated with prevalent systemic to pulmonary shunt. And the third, pulmonary artery hypertension with small or coincident with defect. And the 4, pulmonary artery hypertension after defect correction. We talk one by one, and the Eisenmenger syndrome include all RALC and extracardiac defect which begin as the systemic to pulmonary shunt and progress time to severe elevation of pulmonary vascular resistance and to reversal pulmonary to systemic. or bidirectional shunting. The patient have cyanosis, secondary erythrocytosis, and multi-organ involvement of usual present. And how about the pulmonary artery hypertension associated with prevalent systemic to pulmonary shunt? They divided two, correctable and correctable. So, including moderate to large defect, PVR is mildly to moderate increase. And systemic to pulmonary shunting is still prevalence, and whereas cyanosis at rest is not feature. And the third is pulmonary artery hypertension with small or coincident defect. Marked elevation PVR is present of the small defect. By echo, usually PSD less than 1 centimeter and ESD less than 2 centimeter. So they do not account of the development of PVR. So clinical picture is like similar to idiopathic pulmonary artery hypertension. So the closing of the effect is contraindicated. And the four, pulmonary artery hypertension after defect correction. The congenital heart disease is repaired, but the pulmonary artery hypertension either persists immediately after correction or recurrent development month or year after correction. So there are four clinical classification. This and now this is the algorithm how to diagnosis of pulmonary artery hypertension of congenital heart disease. So the first we must ask the anamnesis like symptom sign, history of suggestive of pulmonary hypertension, and goes to the echocardiography. If the probably pulmonary hypertension high and moderate, go to the diagnostic with the left heart, and go to the refer to pulmonary hypertension expert center. So if have no refer, you can do the right heart catheterization, and we can diagnosis pulmonary hypertension associated with congenital heart disease. This is the management with the pulmonary hypertension with congenital heart disease with left to right shunt. First, still we must see how the patient have the failure to thrive, and how about the oxygen. If oxygen more than 95%, and see from the imaging only left to right shunt is present, they are operable. But is absent, we must do the catheterization, and we have three output with the PVRE index less than 6 Wood unit, or 6 PVRE 6 to 8 Wood unit, there's gray zone, or more than 8 Wood unit. If gray zone and PVR more than 8 Wood unit, you must do the acute vasodilator test for that patient. So if the acute vasodilator test is negative, and you must do the target pulmonary hypertension therapy and repeat catheterization. If still negative, probably the patient inoperable. But if the acute vasodilator test is positive, you can do the therapy and then repeat. If the repeat catheterization and pulmonary still positive, their high risk surgery consider the PET penetration. This is the prognosis. If you have the patient with TGA, FASD TGA less than 6 months, and VSD or PDA less than 1 year, on ISD is yes, go to the still saturation good, and then QPAQS more than 2, go to the not necessary catheterization, and go to the shunt closure. If no, we must do the catheterization. We have 3 output and 1 of the go to the general gray zone. So if the patient not shunt closure or closure still need the pharmacology therapy to exclude the pulmonary hypertension after defect correction.
4 menit lagi, Dr. Wanto.
This is
Oh,
thank you.
4 menit.
This is the gray zone. This is the individual evaluation with the variable lots like age, comorbidities, physical examination, echo, right heart catheterization. Sorry, genetic, vascular morphometric, and nuclear imaging, and then the pulmonary artery stiffness for the evaluation. This is the acute reactivity testing. If definition for the pulmonary vasoreactive response is decrease in mean pulmonary artery pressure more than 10 millimeter mercury, but to reach absolute mean pulmonary artery pressure less than 40 millimeter mercury. So this is the pulmonary hypertension vascular disease of the context single ventricle physiology. The important thing is mean transpulmonary gradient less than 6 millimeter, and then pulmonary vascular assistance less than 3 Wood unit. There is probably mark of limit for completion of palliative aspiration of pulmonary and systemic circulation in univentricular heart. This is the cut-off. American guideline and European guideline is similar, but one use the index like Wood unit, and the American adult congenital heart disease use the between pressure, systemic, and pulmonary. This is the follow-up for pulmonary artery hypertension. We must did the medical assessment, ECG, 6-minute walk test, CTEP, echo, basic lab, blood gas analysis, and right heart catheterization. For baseline, we need all the item there, and then we must repeat every 3 to 6 months or 6 to 12 months, or if the clinical worsening. The take-home message: the pulmonary artery hypertension have the associated with congenital heart disease, and clinical classification of pulmonary artery hypertension with congenital heart disease, like Eisenmenger, and then pulmonary hypertension with clinical to pulmonary shunt, and hypertension with the small or coincident defect, and pulmonary artery hypertension after correction. And the diagnosis of pulmonary hypertension associated with congenital heart disease is based on clinical manifestation, physical examination, echocardiography, and right heart catheterization. How about the treatment? Treatment for pulmonary artery hypertension associated with congenital heart disease is defect correction and pharmacology therapy. Thank you for your attention.
Thank you very much for the very nice presentation, Dr. Indriwanto. Dear colleagues, ladies and gentlemen, I suppose we have already completed the plenary session 2, as we would like to conclude about 2 speakers. Number 1, regarding the new paradigm of lipid lowering in primary and secondary prevention of CAD. We know that improving control of LDL-C will decrease the burden of CVD. And another important thing is combination of statin will increase the LDL-R and increase the survival. Interestingly, that we have new injectable of RNA-based therapy, which is promising something. Then for the pulmonary hypertension and congenital heart disease, we know that the diagnosis is based on both of clinical and echo or right heart catheterization. The therapeutical approach, which will be based on defect correction, as well as we're still hoping for the pharmacological therapy. Thank you very much for attending this very important plenary sessions. We would like to thank you to all of the presenters, I think that we should give applause to the Professor Ray and Dr. Indriwanto. Thank you very much.